keynote address by Dr. Pawan.
So, good morning once again, and thank you so much, Asia Pacific and AIOS for the invite. And we have been in the Bhutan with Dr. Neha, where the similar session of talk was given to me. So, so we know that the retinal bleeds can be subhaloid, subilam, intraretinal, subretinal, as caught in a single frame in one of my patients. Today we'll be talking about the subretinal bleeds. And that too can have a different presentations from minimal to, massive at times involving whole of the macula. But what's the need of removing this blood? First is iron is toxic to the photoreceptor. Fibrin can lead to shearing stress on the retina. These clots can get get vascularized over time and can turn to CNVM. The causes being the AMD, PCV, RAM are the most common causes, and systemic association we know. We call it significant when it is occupying more than 4 distractors of the area. The prognostic wise, the size less than 4 distractors is good, duration up to 2 weeks is better, thickness up to 300 microns, and the etiology, obviously when the choroid is not involved, so like trauma, RAM and Valsalva, the results, the prognosis is better. Like in this case, we had just had a trauma in one of the cases where, just with the pneumatic displacement, the patient got a vision of 6/9. Why? Because the choroidal rupture was just abutting, it was juxtafoveal in the region, and the fovea was split. The similar patient, when it comes with the CNVM with the bleed, 1/8 patients scarring in the other eye, right eye CNVM, we advised the injection with the pneumatic displacement. Within a week, the vision improved, the blood disc got displaced, and within 6 weeks, it improved to 6/12. Advised 3 monthly injection, but as the scenario is when the vision is gained, what's the point? So patient lost to follow-up. Came again after 3 months with a rebleed of vision of 3/60. One-eyed again opted for the same because he had improved earlier with the pneumatic displacement along the anti-VEGF injection. And with displacement now was serious for the injections and got the vision with a 3 monthly or 6/36. In some of the cases where you have a bleed, the fresh bleed over the CNVM, the other eye is good, you can try for the surgical intervention. As in this case, so the surgical procedure is to do the vitrectomy. Thereafter, you do the base dissection because you're putting the gas. Then inspect the area of the bleed, the extent of the bleed. At times, you have to plate this so that raise the pressure inside. Then, with the help of the 38G Medon cannula, subretinal cocktail of air, BSS. I prefer BSS than TPA. I don't know nowadays in TPA. So it's followed by the fluid exchange and partial fluid exchange, I will say, and the patient kept for the sitting position for the 5 days. At times, you can catch this subretinal air and this in the C3F in a single frame. Very rarely you should opt for these RP choroid grafts, I will say autologous. In the cases where the anti-VEGF is totally contraindicated. In the cases where have a 80 years of lady who can come for the injection, someone has told this lady that you will need an injection almost 18 to 20 injections. She said, I cannot afford. Then Ayushman came to our savior, and we did the surgery in such cases at times. So it's the induction of PVD followed by the base dissection, and thereafter you induce a localized detachment in the area of where is the abnormal retina as well as of the area of the normal retina. Do the fluid exchange, it will push all this fluid behind, then do 180-degree RR. This extensive surgery should be tried very rarely, I would stress again. Then you fold the retina on itself. Thereafter, the underlying CNVM complexes as well as the blood and the anterior attachment, you see that has two been separated. Then you eat all this complex and the blood and all this, you try to, and then you cauterize the feeder vessels there. Then from the area of the normal RP choroid, do the cautery for the size of graft. I try to use the curved scissor with which I separate and give the nick and use it as a forceps only. Then hold it at the edge, do not at the center because we are trying to do the RP choroid grafting. Then PFCL is transformed from the underneath to the over the retina, taking care of the graft not to move. Thereafter, you laser and then the routine steps of the PFCL oil exchange, and you can see the result in this case. Luckily, patient also gained the vision. The graft nicely in place and counter finger up to ½ meter. Trauma post-plaque perforation is another cause for subretinal bleeds. Patient came to us, full chamber hypemia. We did the wash, did the lensectomy, and what we saw that there was some large bleeds there, and you see 5. It was perforated at 5 sites and big crescentic macular hole like tear in the center. And You do the vitrectomy, thereafter, the options you sought for, then you try to plug this with the ILM plugs as much as you get from wherever. Thereafter, wherever you get the big flap, you try to cover it over the flap, and then the peripheral holes are laser. Thereafter, do the base dissection, because if you do an initial PVD, try to do the initial PVD in the periphery, you can induce the detachment. And it's over monthly follow-ups and the patient the last. And recently, we did the SFL in the patient gained the vision of 6/36 now. This case is very close to my heart, because manager of our age coming, one-eyed patient turned blind and came to reaches your clinic. It was HDFC bank manager from Delhi, came there, for editing whatever they do in the end and in the September. And the eye was like this, big tear 180 degree in the only seeing eye. You're trying to, under the muscles, you're trying to put the sutures, and almost 180 degree, and you don't see anything inside. There's a detachment and there is a blood. You're trying to induce the PVD. You cannot induce because there's a subretinal blood with a detachment. Then you make a pocket in the hole in this highlight and put a PFCL, try to push it behind. Then you try to take this blood. I tried it with a soft tip first. It wasn't coming. It was big clotted blood. Then I'd use the endolite in my left hand to put some of the counter traction, but still it was not coming. Then I'd use this cutter, and we call it the spaghetti technique, on which we try to roll these big sheets of the clotted blood over itself. The rest of the blood is taken of the loose blood, and it is followed by the routine procedure. And this was we left the PFCL because whatever the PFCL I was putting, it was coming out of the big tear. So there was no option than putting a PFCL for some time and making the patient lie straight, because so that the retina settles to some extent. Then using this suture, Prolene suture, which will try to hold the oil behind, and in the second setting, and nothing can be more satisfying to see the patient coming to your clinic, himself in your center will try bypass the Sardarji himself. And this is one of the things which we try to strive for. And now, last month, 2 weeks before, he has come with the sweets. Uski beti hui hai, and nothing can be more happiness, give you more happiness than this. So this is diabetic with subretinal bleed. The lady from Saharanpur came to us. Otherwise, NVG, the right eye, you see, we do the vitrectomy, then try to do the vitrectomy, then you see, oh my God, still a lot to do, a lot of membranes, a lot of blood lying there. You try to put the orocords, try to separate it. Then you make a sort of opening there, try to stabilize with the PFCL, blood piche na chala jaye, thoda bahut phobia bacha rahe. Then you make an opening and try to take all these clots and all this clotted blood from there, loosen blood, you try to do. Diabetics is the biggest challenge nowadays. And thereafter, the patient was blind for more than a year, and 6/24 she gained. At times you have to take these big hard exudates, subfoveal clots by making a retinotomy. No option you have in blind patients. And you can see that retina is being settled when they do the scan, raster scan from up to down, and the patient gained the vision of quantification 1 meter. Unfortunately, after 18 months, she turned up blind again, because this is, I could help out for this 18 months, but we have to accept the truth at times. In the end of cases, at times you have a serosanguinous bleed. To drain that, just place this cannula halfway, and this come itself, and not push it totally in, because the retina can get incarcerated and put a pressure. So to conclude, I would like to say that minimal bleeds you can observe or give anti-VEGF depending on the cause. Slightly more, go for pneumatic displacement. If your patients have a good other eye, then go for the surgical procedures. And subretinal BSS is better than the TPA, because TPA doesn't have seen it doesn't migrate to the studies by the Kamai and the Levi's have told it doesn't migrate to the initial people used to give intravitreal, you have noted, but now they're trying that, and then they tried subretinal, because it doesn't penetrate the retina per se, and need to have some break, and very, very rarely, I say, use opt for such extensive surgeries. Thank you everyone for the patient hearing, and especially to my teachers for all the learning I have.
Thank you, Dr. Pawan. It has been a very nice video session and really heroic surgeries, and giving some vision to the patients where everything is lost.
And someone has to take a call, because doing surgery in such cases, even if you gain 4 of the patient of the 10 you operate, it gains 6 will curse you, but we have to be happy with these 4 who comes to your clinic walking. Thank you so much.
We can understand how difficult it is in the OT when you're sitting for long hours and seeing what would the result. You never think of that. You just do your best.
Thank
Thank you.
Thank you so much.